conference will now be recorded.
Greetings, everybody. It's John Antonucci. I'm going to be moderating tonight's group. This is AnCan's High-Risk Metastatic Advanced Prostate Cancer Discussion and Support Group. It's March 24th, 2026. We're going to get started in a minute, but first I want to express our gratitude for some of our corporate sponsors, which are Telix, Blue Earth Diagnostics, Foundation Medicine, and Novartis. Now, to give you new guys a little bit of an update on how we work here, we first, anyone that's new that doesn't mind getting a little history taken so that we can all get to know you, we'll spend the first half of the group approximately talking to you new guys, introducing you to everybody, getting your history, and starting the process of supporting and guiding you through your treatment. Then we'll go on to the regulars, and we'll try to wrap up in about by about 2 hours from now. For you guys that are new, and for anybody else, I want you to know, first of all, that we are going to discuss a lot of things about treatment and our own experience, but we're not giving you any official medical advice. We urge you to take anything you learn here back to your providers and discuss the outcome with them, and anything you learn from them to bring back to our discussion. The second thing is, if you do decide to follow up with us, we don't always meet on a Tuesday. We alternate Mondays, the first and third Monday of the week at 8 p.m. Eastern, and the second and fourth Tuesday of the week at 6 p.m. Eastern. We sometimes forget ourselves and tend to sling around a lot of jargon in here. I don't want anybody to let that go. If there's something you don't understand, I don't want you to sit in the background and not know what's going on, because by the time you've been in this group for quite a while, you'll get pretty sophisticated in your knowledge about prostate cancer. So speak right up. You can communicate with us by speaking up or by raising your hand. You see in the lower left, there's a hand that you can raise, and I will recognize you and find out what your question is. And we also have a chat window in the upper right of your screen. There are two square boxes with the number 1 next to it. If you click on that, you'll find that you'll be able to communicate with all of us, or just any one particular one of us, and get your questions answered. Now, there's some things that I'd like to know about you new guys, and so I'm going to start with Morgan, if he's willing, and ask you some questions. I already know that your age is 53 and that you've attended the under 60 prostate cancer group.
Correct.
Some information was already collected there, but we don't know it. So tell me first, where are you from?
Big Sky, Montana.
All right. And how old were you, by the way, when you were diagnosed?
52, a year ago, March 21st, 2025.
How did you get diagnosed? How did you come to the attention of urology?
I had been having quite a bit of pain in my tailbone and had seen different doctors for that pain. Nobody seemed to know what it was. Finally saw a doctor that took some blood work, and my PSA was 220. Immediately sent me to a town an hour away where I saw the urologist. He did a biopsy there.
Well, congratulations to that doctor for taking something that sounds like an orthopedic problem and discovering that it really was an oncological problem.
Yeah,
Well,
I thought I had fallen on my bike or skis or something.
Yeah, good. What happened after you saw the urologist?
Biopsy came back as a 9. Gleason score is 9s. Then PSMA and started on ADT, started chemo a couple weeks later.
Slow down a little bit. I'm going to get a few more details. Was your Gleason 9 a 4+5 or a 5+4?
4+5, I believe.
Did it have any unusual features mentioned, like the form or intraductal or anything like that?
Not that I can recall. I can go back. I don't recall anything like that.
They've also sampled any lymph nodes.
Yeah, I believe they did.
And were they negative or positive for spread?
Negative. It was spread to my bones, only in my bones. There was 10 mets on my pelvic region and 1 on my skull.
So this must have been discovered not by your biopsy, but by a follow-up PSMA test, right?
That's correct.
You said 10 bony mets?
10 in my pelvic area, 1 on my skull.
Are there any soft tissue metastases like liver, lung, or lymph nodes?
None.
Okay. And then after your PSMA test, what happened?
Let's see, I guess then we started on the chemo shortly thereafter, the doxycycline and the ADT. Started on the ADT right away. And
ADT plus chemo plus also an androgen blocker, or just the 2?
all 3.
All
So
3,
I was,
okay.
yeah. And then so the chemo lasted till the end of July and did another PSMA towards the middle of July. Everything, the 1 on my skull was pretty much gone. There's the uptake was reduced significantly. PSA was dropping, and yeah.
So your follow-up PSMA tests showed shrinkage of skull and some other bony mets.
Correct.
And probably also some shrinkage in the prostate gland itself?
Yes.
Okay. Good response to triplet therapy.
Yes.
And how about what's going on since then with your PSAs or any other scans or symptoms?
Yeah, so I switched to Lupron at the beginning of October.
From what?
I'm on Lupron and Xtandi right now.
What did you switch to Lupron from?
I was on Orgovix.
Okay.
And then I had another PSMA PET scan in October that showed even better results and more, a lot less uptake. And then I had a radiation on my prostate at the end of January, beginning of February, SBRT. And so now I'm on just the Lupron and the Xtandi and feeling pretty good. And my PSA is down to 0.45.
Is that the lowest it's been ever?
Yes, the lowest it's been.
You had your radiation treatment in January. What did they radiate besides the prostate gland, if anything else?
Just the gland right next to it and a small bony met really close to the prostate. Sorry, the sacral, or sorry. They did not They did not radiate the sacrum. So sorry.
And what has happened with your pain?
My pain's pretty much zero.
How's your general medical health?
I would say I'm very healthy, very active.
You eat well, and
I immediately changed my diet. I'm vegan, and I gave up all drinking. So I haven't had a drink in a year. Haven't had any meat since I was diagnosed.
pressure's good.
And I live in Montana. So.
Okay. All right. Gee, you're doing everything really well. Did you who's been running the show here? Who's been your radiation oncologist and your medical oncologist?
So yeah, I mean, I when I got diagnosed, I kind of freaked out and tried to reach every cancer center in the country almost, it felt like. And I have Dr. Zakaria at the Mayo Clinic in Phoenix is my oncologist. And then my rad onc for my radiation on my prostate was Dr. Tang at MD Anderson in Houston.
I didn't catch your oncologist's name.
Zakaria. Z.
Oh, okay.
H-A-R-I.
And your radiation oncologist is at MD Anderson?
Yeah, Tang, T-A-N-G.
Okay. Gee, you've been doing a great job with everything, you know, getting a good team in place, getting active, modern treatments, and exercising, eating right. And how did you wind up with us today?
Actually, as Jeff recommended it, what's your last? Sorry, got to get my glasses off. Jeff Marchi recommended a while ago, and I put it off and was kind of just plugging along on my own path, but recognized that I could use support, and I'm really glad I'm able to join. I got onto like little chat rooms or different groups or different groups on as far as chats and things like that, but never really had joined a online support group. So
right. How's your support otherwise? Married, family, friends?
Yeah, my wife, 2 kids, super supportive. I got friends and family that are supportive. So yeah, I'm extremely lucky with my support group, but I don't think, as everybody on this call fully recognizes, nobody knows what we're going through, right? Like,
yeah,
you have, right? So it's tough when especially, and I probably shouldn't say especially at my age, but when you're hit with this at 52, it was tough, especially, and I mentioned this in the under 60 group, small town Montana. The doctor that diagnosed me was saying I had an exotic, aggressive form of cancer. When I was diagnosed, I didn't think I was going to last a couple months, let alone a year. So I'm happy to be here a year later. So maybe that was all.
Why did he say that, Morgan?
Why did he say?
Yeah, why did he think that you had an exotic form of prostate cancer?
Well, I'm guessing because in my town, he probably doesn't see it very often at all, let alone in someone my age. And so therefore he kind of felt like this, and with a PSA of 220, I think he was just not someone that had been around it. And then I went down to the Mayo Clinic, and Dr. Zakaria is like, okay, yeah, this is,
yeah,
same thing every day, right?
Yeah, we see it. I mean, Well, the reason I was asking is just to make sure we hadn't missed anything and there were any unusual features of your cancer that we hadn't heard about. But it sounds like it's a common garden adenocarcinoma that's pretty aggressive. That were you getting tested every year before that?
No, my previous PSA was when I was 47 years old.
Yeah. So, yeah. And that's what happens. It gets away from you and you don't realize. So, yeah, I mean, but it sounds like it's really under control. I'm curious why you didn't go to Huntsman.
In Utah?
Yeah.
I don't know. I mean, those first days of scrambling to find, I mean, I was faxing my medical records to, Fred Hutch, to University of Oregon. I faxed my records all over the country. I felt like,
yeah.
And I mean, I would have got, and I guess one of the reasons I liked MD Anderson was I have a brother-in-law that 16 years ago was diagnosed with colon cancer, and he went there, and he's still alive, So it was one of those things. From my town, Phoenix is pretty easy to get to from where I'm at as a nonstop flight. So So it was a matter of scrambling to where I could get in and trying to get into the best, any cancer care center I could. So.
And why did you switch from Orgovyx to Lupron?
My liver function was my liver numbers were getting really high, and they were worried about that. So rather than.
I mean, go back to normal?
Pardon me?
Did your liver test go back to normal?
Yes.
That's interesting because we've not heard that that Orgovyx would have any different effect on the liver markers than the Lupron. I had trouble with my liver markers on Lupron. So, any of the docs on the call, any suggestions as to why the Lupron would be gentler on the liver than the Orgovyx?
I would call that idiosyncratic. In other words, I think he has a particular sensitivity to a drug that in general would not be a bad offender. We would have probably suspected the Xtandi, at the time rather than the Lupron. But whatever it was it was perfectly executed because you made a switch and your liver test got better. Has Dr. Zakaria gotten any gene testing on you?
Yeah, I've done gene testing, and they haven't found anything where they can do anything different. It's gone to Tempest, I believe, is the company that they did it with.
What was the sample that they tested?
I don't know that. I'd have to get that for you.
Was it blood, saliva, or the biopsy?
Oh, I was pretty sure it's saliva. Sorry.
Okay.
Not if it was Tempest. It wouldn't have been saliva.
Okay.
It would have been either your blood or it would have been a tissue sample.
Okay, I'll have to find that out then. I know I've gotten results from both Tempest and Invitae.
Yeah, the Invitae would be saliva.
Okay, then I'll have to check what I got.
Yeah, Dr. John raises an interesting point, and it's something to talk to Dr. Zakaria about, which is that if they took the sample that they sent to Tempest from your prostate, then maybe they would want to send something from a distant metastasis to Tempest, because that can be significantly different. And Usually if we were to do a blood sample, we'd pick it up, but it might be too late to do a blood sample now because you're responding so well. So what I would say, it's not a huge issue, but it's definitely something to discuss down at Mayo when you're there, as to whether you would want at some point a retest with a metastatic sample.
Okay.
Got any questions for us?
Yeah, I mean, so I had a lot going on as far as what I radiate prior to selecting to only radiate the prostate. There was talk of radiating the sacrum where, the largest met was, but was causing zero pain at this time. I mean, when I initially was diagnosed, my tailbone, I would say, was a 4 or 5, and now it's a 0. So I said, let's only radiate the prostate. The question is, was that the right decision? And is there a reason I should have radiated more of the bones at this point, or hold off?
Well, you're asking in retrospect what you should have done or going forward?
Well, I guess going forward, is it make sense to hold off on any more radiation or till there's pain or till the PSA changes? I guess at what point do you look to do additional radiation?
Anybody have any comments about that?
Well, I have one comment, which is I would certainly progress with radiating the primary, because we have some pretty good evidence and pretty good studies that to radiate the primary probably makes sense.
He did it, Rick.
Yeah, I radiated the primary at the end of January.
Well, I thought you said that was just to the metastases and that you had SBRT coming up for the gland.
No, I radiated the prostate. SBRT.
Oh, so you radiated the prostate back then, and you radiated how many spots back then?
No other spots, just right around the prostate.
Okay. Then I would probably say wait and see what happens.
Yeah, I would also be inclined to say when you're radiated, when your imaging shows activity in an area, that would be a good time to think about radiating that area. Right now, it seems like all these spots are so quiet, the cancer cells are probably barely dividing at all now. So, any other contradictory opinions to that? Would anybody go aggressively after any of these spots now? Yeah, I think you're good. You've had a wonderful response to triplet therapy. I wouldn't be surprised if your PSA doesn't drop even further.
Okay. All right. Well, thank you. Any more questions for me? I mean, I appreciate this. I'll just keep plugging along and trying to stay off the. Let's try to stay active.
A couple of things that do occur to me. First of all, were you able to connect with any of the other young dudes on from the under 60s, like Matt or Adam or any of those other guys?
Danny and I exchanged emails, so I need to connect with him more. I think I can, but he was the only one I connected with, Danny.
Okay, so there are, I mean, Matt is terrific. Adam Alvarado is great. They've all been where you are. I think Adam, if I remember correctly, Adam PSA was 1,000 when he got diagnosed. So, and they also have kids like you have kids. So And a lot of that, you know, a lot of the issues do arise. Well, how do you deal with this with your kids? And I know we talk about that in the under 60s. We won't go into it here, but definitely it's a really, those guys are terrific resources. And if you want to reach any of them, just let me know, and I'd be very happy to connect you. Are you still working, Morgan?
I am, yes, I am still working.
And from home?
I work out of my house, so that makes it nice.
Okay.
Do you and your wife plan on any more children?
No.
Okay. Any other kind? Oh, I see. Oh, sorry, Rick. Was that you?
Yeah, please tell your wife that we have a really good Care Partners group if she'd like to use it.
Oh, that's great to hear.
Okay. It's for mostly for people with advanced, mostly for people with advanced cancers or any advanced cancer. But there's a lot of wisdom in those groups. And also we've got care partners that we know that may not attend the group, and we can find some one-on-one support for her too if she'd like that. But you just got to let us know, because it's not something we normally do, but we can do it. And we know where the support
Very
lies.
helpful. I appreciate that.
But the Care
George,
Partners
what's on
group
your
is a
mind?
great bunch of women. Go ahead, John.
George? George, you got your hand up?
Yeah, I want to introduce myself to Morgan. I have similar stories. I was 51 and was diagnosed with diffuse metastatic cancer, which started in my spinal cord. I got spinal cord compression of my thoracic and lumbar spinal vertebrae and my left hip, my shoulder. I had pretty much diffuse metastatic disease. And yeah, I had two boys, both in college, and I had the same thing that you had. I had doctors looking at me like I was on my last leg, and that was 14 years ago. So so you can you can maintain a low PSA. I mean, I guess it's learning how to live with it, and I'm every day I wake up, I'm grateful. I just I like talking to guys that have advanced disease and even unadvanced disease. When you get diagnosed with advanced prostate cancer, stage 4, like any other cancer, it's that feeling goes through you. And luckily I had aggressive treatment like you have gotten, because they weren't doing that back then. They were doing single chemo treatments back then. They didn't do anything with the prostate. I still have my prostate in, and I'm happy to say it still functions. So and I went over this with my oncologist, Dr. Morgan's, about whether I should whether I should radiate the prostate, because the chance of me having another cancer pop up is it's present. But we've been following my PSA for the longest time now, and I get it every 6 months now instead of every 3 months. But yeah, I'd be happy to talk to you anytime. It's always tough when your first diagnosis you get is you get cancer everywhere. Mine unfortunately caused a lot of pain, and I still have a lot of pain. I had three spinal fusions. I've been on every narcotic known to man, and I'm finally getting on methadone, which has really helped my pain quite a bit. I think it's the only thing that's helped me. And I'm sure a lot of you guys have had problems with doctors that that view narcotic use in advanced cancer as something that they don't want to do anymore. Tides have changed on that one. So,
Thank you, George.
but
When
I'm just
we
glad to
catch up
be
with
here.
you, when we catch up with you later, we can talk a little bit more about the pain aspect, but
Sure,
wanna-
sure.
Yeah,
But I'm glad to hear your
Morgan,
story.
yeah, George, thank you so much for letting me know. I definitely want to connect with you. I really appreciate that.
just
Put my
use the
number in
chat
the chat.
to
Yeah,
give each other your contact material, okay?
yeah.
Yeah.
I am
Use-
actually going to move on because I have three new.
Hold on one second, John. Use the chat. And what I was going to say is I've also signed you up for Men Speaking Freely. I just added the care partners, so that'll come to you. Your wife can sign up individually, but to begin with, it'll come to you. I also added Men Speaking Freely. And John, do you just want to say a couple of words for the benefit of people listening and those who don't know about Men Speaking Freely, especially the new guys?
As you guys can see, we spend a lot of time on technical aspects of your cancer in this group, although we do need to know about things like social support. But Men Speaking Freely is all about mutual social support, discussing men's issues and all the particular things about having chronic illnesses. It meets twice a month on Thursdays at 8 p.m., first and third Thursdays at the same location here. I'm going to move on to you, Ann, and we have a new guy that I know just a very little bit about named Chuck. Chuck is 88, a veteran who was referred by Jim Marshall. He was diagnosed not long ago. We'll find out a little bit more about it soon. He is a 4+5 with cribiform and is just about to start treatment. So, Ann, can you tell us where you guys live?
Yeah, we live in Virginia, and just outside of DC in Alexandria.
Okay. And when was Chuck diagnosed?
About 40 days ago. We're at the hospital for a completely different reason, for constipation. They did an CT scan, found a mass, and saw a urologist a couple of days later. Took a biopsy, and came back with the Gleason scores, and then he had a PET scan and a PSMA.
What was the result of the PET scan?
Metastasis to the bone.
Where?
The largest metastasis is in his left hip.
Okay. And how many metastases to the bone?
Oh, gosh, I don't know the answer to that off the top of my head.
Okay.
Several.
Were there any soft tissue metastases?
One small spot in his lung.
Okay. Boy, you guys, the ink isn't even dry yet on the biopsy report, just a few days ago, huh?
So they move fast. His PSA level was 3,100. They immediately put him on Firmagon and Casodax. Then we saw the oncologist. They did another PSA after, I don't know, about 25 days of Casodax and the Firmagon, and has come down to the 390.
Good.
And now he just started Xtandi, Lupron, and Zometa.
So the Zometa now, is that because of the bone mets?
It is.
Okay.
It is.
Did
And they
he
haven't done it.
Did he get one of those DEXA scans that?
Not yet.
Okay.
Not yet.
Okay. And how's his general medical health?
For someone who's 88 years old, it's actually pretty good. He has AFib, controlled high blood pressure, but otherwise he's still pretty active and in Okay, health.
Excellent, excellent. You know, a lot of, it may have been a while before, there were some recommendations some years ago to stop doing PSA tests after people got into their 70s. And when was his previous PSA test before this 3100 one?
Oh, I'd say 20 years ago.
Yeah, yeah.
So it's just been lurking there for a long time. No indication that anything was wrong with him.
Yeah. Okay. Okay, very good. And did any of genetic testing get ordered yet, or is it too soon?
No, they did. We haven't gotten the results back, but they did take blood for a genetic test, and I would expect those results back in the next week or so. Or we would.
Family history of cancer?
None. None. He was boots on the ground in Vietnam, so whether Agent Orange comes into play.
Did he get exposed to Agent Orange?
Yes.
Okay. And you've got a Dr. Feigert or something like that? Did you tell
Correct.
me that? Okay. And that's go ahead.
I'm sorry. He's with Virginia Cancer Specialist.
Okay. All right.
And what's the name of the doctor that he's seeing?
John Feigert.
Okay. Is he a genitourinary specialist or is he a general medical oncologist?
Jim says he's a general medical oncologist. Is that true?
He is with a special interest in the word I can't pronounce.
Genitourinary. So, you know, what we would say, and Jim probably said to you, is a special interest probably in today's world is not enough because the science is moving so quickly.
Okay.
And if you have the flexibility to switch, we'd strongly recommend you consider doing that.
Okay. No, we were going to get a second opinion. There's somebody that's close to Sibley Hospital, Mark, that we were.
Yeah, Markowitz is at Sibley, but
yeah,
I would kind of send you to Channing Pal. I mean, Markowitz is really good, and he's especially good if it's an unusual type of cancer.
Okay.
And I think, Richard Craymond is on. I think that's who Richard Craymond is here somewhere. I thought I saw him sign in.
Yeah,
and he'll say something. He'll say something. The other doctor, and that's who he sees. I think I forget his exact name, but it's the doctor that Richard sees. The other person that we really like there is Channing Pala. She's really great. And Channing, I'll put a link in the chat window for you. Those are the two little squares. And we'd like to see, is this your dad? I'm assuming it's your dad.
It is not.
Oh,
it's my husband.
Oh, it's your husband. Excuse me.
Husband. I'm younger than what I look, and he's old. I'm older than what I look. So
you're older than well. Excuse me. I didn't mean to put my foot in my mouth.
No. That's fine.
Well, it's just that we really like centers of excellence, especially where there's some complication. You know, in this case that we have an 88-year-old gent. Sounds like he's doing well. I think I heard you say that his biopsy results are not back yet. Is that correct?
No.
His gene tests are not back yet, but his biopsy results showed a 4+5 crib.
Okay, so we didn't mention that before. So 4+5 with crib reform. No IDC, right?
No,
Did it identify whether it was large or small crib, John?
Jim didn't tell me that. If you'd like, and you can mail me or Rick his biopsy report, and we'll have a little bit more detail. And another thing I would like you to do is to have a visit with the cardiologist, because
Yes.
a lot of these medications can play hell with the heart rhythm, what we call the QTC, well, I won't get technical, but with heart rhythms. And I'd like you to be really closely involved with cardiologists, especially as medications change.
Yeah, that's a great suggestion.
How frequently should he see a cardiologist?
Well, let's just step back one. It's not just a cardiologist that we want him to see. What we would really like him to see is a cardio-oncologist, because the cardio-oncologists are a lot more familiar with how these hormone therapy drugs that he's taking are going to interact with his AFib situation.
Okay.
So what you really need is, if you can find one, is a referral to a cardio-oncologist. And I suspect that Sibley will be able to do that. If Sibley cannot do that, then we can help you. We know that there are people at in Philly, further than you want to go, but there are cardio-oncologists there. But I suspect there's a cardio-oncologist at Sibley.
Okay. Okay, I'll look for one. Thank you.
And tell us, this is perfectly all right. We love to have you. We'd love to have you just by yourself. But why are you here by yourself?
Because I think I am more of an advocate for Chuck than what he is going to be for himself.
Yeah.
That's why.
Okay, we've had other people we've had other people whose wives have led the charge, and they've come in weeks later, so it's not unusual.
Yeah, I would suspect that he will join over time as well.
Yeah, great. And other questions that occurred to you, Ann, or does anybody else in the room have any questions or comments for Ann?
I have one comment that I missed the right button. This is Richard. Is Mark Markowski up at Sibley, and the GU oncologist. I had good luck with him.
Right.
Okay.
Right. So either Dr. Paller or Dr. Markowski, and I know Richard has been really happy, but Richard has a very unusual type of prostate cancer.
Yeah.
I think, but both would be good.
Okay.
Yeah.
And Jim Marshall sees Dr. Paller. So we cover the bases here, Ann.
I'm going to go right on to our next new guy. Thank you, Richard, for chiming in. Go ahead, Rick. Sounds like you have something else.
I'd like to hold on just a tad. We have some octogenarians here on the screen. And I just like, we have at least two that I see, and I don't know who else might have snuck in on the QT when I haven't been looking. But I would like the octogenarians, if they have any words of wisdom for Ann, to speak up.
See the cardiologist.
I'd like to give you a referral at Innova. Did you say you're in Washington? A cardio-oncologist who's highly recommended is Anna Barac, Anna B-A-R-A-C. She was
Thank you.
recommended to me by Dr. Belusic, highly recommended. And since you're in the Washington, D.C. area, you're talking about Sibley, my old home base
Oh,
neighborhood.
yeah.
Anna Barrick is top drawer cardiovascular cardio-oncologist at Innova Fairfax.
Yeah,
Perfect.
that's great. Jack, Dr. Jack, will you put that in the chat window for me too? At least the spelling of her name so I can track her down.
Okay.
I was thinking that was going to come from Dr. Paul and not from you.
I'd like to ask Ann 2 quick questions. Did they presume that the constipation that your husband presented with was secondary to the pelvic mass or the prostate enlargement and pelvic obstruction?
They did not relate that. I think that was just coincidental.
True, but unrelated. Yeah. And
Yes.
is he feeling, would you say he's feeling generally better now than he did before he went in the hospital, despite the medicines and such?
Yeah. Yes, I think so. Except for his walking, I think what has he has a little bit of pain, not a lot of pain, but a little bit of pain in his left hip. And, prior to a month ago, he wasn't using a walker, and we've gotten a walker until he just feels more steady.
Thank you,
Well,
Rick, for that. I'm really glad for both of those octogenarian comments. Paul, were you finished? You're finished? Okay. Yeah, thanks very much. We really love to link up people who have things in common. And forgive me for being in a hurry. I do still have another new guy. His name is Nick. Let me find him in my, there you are. Hi, Nick.
How you doing, doctor?
I know very little about Nick, so I'm going to start from scratch. You get the idea of what we're asking about. I know you're from South Carolina. How old are you?
71.
When were you diagnosed?
The first time was 2015.
That implies that you had a period of stability and then a recurrence?
Well, they took it out. Probably the first 5 years after that, the PSAs were coming back normal. And then my primary retired. It took me about a year to find a new primary. And I guess they stopped doing PSA tests.
And then what happened?
Came down to South Carolina last year. Took about a year to find the primary. Did the blood work and came back with a PSA of 9.7.
So the break between PSAs, was that years even?
Yeah, probably a good 3-4 years.
Okay, so during that time, your prostate cancer, which had been put way down for 5 years, has come back again. Now, can you recall all the way back to 2015 what your biopsy was like?
Can't remember the Gleason scores. I don't think they were more than a 7, but I don't know if it was 3 + 4 or 4 3.
Did you actually get a new biopsy with this recurrence, or are they just heading right into treatment?
No, my prostate is gone. It was removed.
Nothing to biopsy. Yeah, okay. So tell us what's happened since the PSA of 9.7 was discovered.
Went to see a oncologist over here in the neighborhood, Dr. Panica. Basically said, we should start some treatment. I went on the Lupron and the Erlita.
Lupron and what? Erlita?
Yes.
When was that?
Probably 5 weeks ago.
How's it going so far?
So far, so good.
Did Did any MRI or PET scanning take place?
Did a PET scan back in probably like January,
Yeah.
and it came back that I had 2 litinoids in my groin, and one on my third rib bone, and there was 3 other markers that he said that were very dim in my bones. One was my 5th rib, the right shoulder, and one in my left hip.
Would you mind mailing me a copy of that PET scan? These PET scans sometimes come out with really vague, really equivocal findings that maybe they represent further cancer spread, but maybe they're artifact. I mean, not that I'm an expert that could make that call, but I'd like to know, you're the second guy in a little while that we've had some really faint findings, and I'd like to see what they were. Rick will probably put my email address in there for me. Okay, Nick?
Okay.
Do you have any pain in any of these bony spots?
No, a little on my left hip, but I've had that for years, probably an old football injury coming back.
Okay. I think it would be helpful maybe even to dig up your original biopsy for us. Are you a veteran, Nick?
No.
So the doctor that you're seeing now, you mentioned a name that I didn't recognize. Could you say it again?
Panicker, Panicker.
You know this person, Rick?
No, this is just a local medical oncologist. Is that correct, Nick?
Probably.
McLeod Hospital.
McLeod, yes.
Okay.
And tell him about the other doctor, Nick.
Then I went to a second opinion, and it was a Dr. Yin, Y-I-N, in Thailand, Health Oncology in Myrtle Beach, and they're associated with the Medical University of South Carolina in Charleston. And he basically says, what you're doing is good, but he started talking about doing chemo also.
So, Nick, the issue here is really how many cancer sites you have. And it sounds like you've got around 5.
5 or 6. 2 in the litinoids and 2 in the ribs, 1 in the shoulder, 1 in the hip. But he said the only one that really showed up on the PET scan was the one on my 3rd rib on the right side.
And right now they've put you on again. What are the medications that they've put you on?
Lupron and Erlida.
Apalutamide, Erlida. Yep. And did he, before he put you on the Lupron, did he put you on bicalutamide?
No.
No. So that's sort of a test question. It tells us that he doesn't really know a lot about prostate cancer.
Well,
The reason is that when you start on Lupron,
yes,
you really need to be on another drug at the same time or 10 days before. So now there's some controversy. They could give you the other drug at the same time. Did he start you on the Lupron and the Erlida exactly at the same time?
yeah, about 2 to 3 days difference between pharmacy getting the Erlida.
Yeah. So it's more controversial than it used to be. Back in the day, when Dr. Shellhammer was practicing, he would have always given the bicalutamide 10, 15 days ahead of time. Now, there are some docs who say, we can give them at the same time. We don't necessarily subscribe to that. And the reason is because the way that Lupron acts could cause some issues. We would much rather see you with a doctor who specializes in prostate cancer.
Okay.
And you might have heard me mention to Dr. George early on the name Dominic Moresi.
Where is
Dominic was one of my co-founders for AnCan many, many years ago, along with Rob Baniskas, who this room is named after, and a couple of other people. But when Dominic decided to move to Wilmington, he did it because he felt it was within striking distance of the doctor he wanted to treat him. And Dominic's no longer with us. He was young. And his name is Dan George. And Dan George is still a very good friend of ours at AnCan. He's a wonderful, wonderful doc, and he's at Duke. And I know that for you to drive to Duke versus, say, driving to Charleston or somewhere like that, there's not a lot of difference. And I would say to you that if it were me, I definitely would want to be treated at Duke for the right treatment. So that's the first thing. And I'll put Dan George's name. And if it's something you want to do, I'll write to Dr. Dan and I'll give him a heads up. And if he's not available, there are other very good docs at Duke that we like. Andrew Armstrong, and there's a younger lady who we know there. But we would much rather see you cared for at Duke than by a local oncologist. That's the first thing. The second thing is, there is, but it might be too late, there's a really terrific trial going on, clinical trial. Unfortunately, it's on the other coast to you, but it doesn't take a lot of treatments. However, usually you need to have been off hormone therapy for at least 6 months. And you just started your hormone therapy.
Yes.
Why do I love this trial? Because with this trial, you don't have to take hormone therapy and you don't have to do chemo. So, yes, that sounds good. And what it does do is it uses this new radionuclide treatment that you've probably seen advertised on the TV called Pluvicto. And usually we bring that in at the very much later in the disease path. But this doctor at UCLA in Los Angeles is looking at giving a treatment of radionuclide plus radiating the metastases. So in your case, it would be 5 shots of radiation, 5 successive days, and you do that about 4 or 5 weeks after getting a treatment with the radionuclide. And we like it because we think that it could be very effective and it could be easy on the patient. And we got one guy talking to Dr. Kishan right now about it, although he happens to live on the West Coast. We've got a couple of other guys looking at it seriously, but I wanted to bring that up. And it's certainly something that you could discuss with Dr. George. But the problem is, you could even write to Dr. Kishan and say, I just started would I be eligible if it's something you wanted to consider? And I'll put that trial in the chat window for you too. It's called the Andromeda trial.
Okay. I'd like to see the Duke doctor there, George.
I will definitely reach out to Dan to Dr. Dan, and I will ask him if he can see you, and if not, can he get you into somebody, to one of his people? And I really trust him. He's the chief there. He's the chief GU, but they have a number of really good genitourinary medical oncologists at Duke.
Okay.
Really good.
Yeah, I'd like to do that. And this past Thursday, I went to see the Dr. Panica, and my PSA is down to 0.3.
Yep. And it should go right down to undetectable. How long have you been on the drugs?
30 days.
Yeah. So you're responding just like we hoped you would. You would respond. If I'll put this trial in the chat window. If you're really interested, we can probably reach out to Keishan. You can, or we can, and you can find out, what you would have to do. And he might say, well, you may need to stop taking the drugs right away, but there's a lot of schlepping involved.
No, that's the problem.
And you may not want to do it, but yes, we'll get you sorted out for sure.
If it was on the East Coast, I definitely would have did it. Even if it was up in New York.
Yeah, I don't think I haven't heard of anyone doing a trial for somebody like you. I mean, the irony is I said to Dr. John, you're about the third or fourth person that's come into the group recently who's had a relapse after a long period of time. And one of the reasons we know about what is available right now when you relapse after a long period of time is because you're not the first person to come to us with this in the last 3 or 4 weeks. I don't know if anybody's doing radionuclide plus SBRT on the East Coast, but we can look into that.
Okay. That'll be
Yeah,
good.
I would be very happy for you to see Dr. George. That would be great. And soon, not because you're in some kind of immediate danger, but because the decision about whether to follow Dr. Yin's advice about adding chemotherapy probably should be made pretty soon.
Okay. Like you said, now I'd rather do it at Duke.
Right.
I have to do chemo. I'd rather do everything there.
Are you married?
Yes.
Okay, and you have friends and family and social support?
Yes. I got 2 daughters, 2 granddaughters, a brother.
Okay, great. And you heard us talk about the Men Speaking Freely group also. Have you ever had any genetic testing?
Yes, I just started it when I did, when I first seen Dr. Panica. Some of it came back. I know there's no BRCA. I don't know if there's, some other stuff didn't come out let me just see if I have it here.
No Hawks either.
No Hawks.
And we have to give a shout out to Sal.
Yeah, thanks, Sal.
Sal made sure that he did his genetic testing. So
That's
thank
right.
you, Sal.
That's right.
Does anybody have any? Go ahead, Sal.
I said the only other thing is, where I probably might have started the prostate cancer. I was down in ground zero on 9/11 on that day.
Ah, yes. Are you tied into those compensation resources for 9/11?
Yes.
Okay. Because we actually did a webinar on that several years ago to that with that lawyer. I forget his name now. If you're tied in, we don't need to do it. But there is a webinar on our website about it.
Yes. And that was funny because I was going to the clinic up in New York for the last 3 years, and they did blood work, they did lungs, they did everything. And that one time did they do a PSA test?
Yeah.
Well,
how's your medical health?
Was that specifically a clinic for 9/11 survivors?
Yes.
I can't believe, you see, So this is where I go, hello? Hello, they know. That makes me crazy. Because those guys know that there's a higher risk, and we've talked about it. I should write to this doc and say, you know, they didn't test for PSA. I might do that, reach out to him. I can't remember his name, but I'll find it. I'm going to do that.
How's your medical health?
Good, very good.
And as you all also inferred from what we talked about before, if you can stay active and eat well and avoid alcohol.
Oh
and
yeah,
smoking.
yeah. I go to the gym 3 days a week. My wife
Right.
watches what what I eat now. You know, no sugar, no. Yeah.
All right. Do you have any other questions, Nick?
One or two. I know my wife keeps on saying about fasting. 24 hours or 48 hours.
I wouldn't bother. There's been a lot of real interesting debate about this over the last several years, and there may be some health benefits to having a period during the night where you're not eating for maybe, I don't know, 10, 12 hours and not going to bed with calories running through your system. But I think anything more than that, I wouldn't stress yourself or your system by doing. Maybe, if you're interested in the fasting thing, do something like, stop eating at 7 p.m. and don't start again until 7 a.m. or something like that.
That's usually the time. Even longer. I usually, have dinner around 5, 6.
Yeah,
And then probably have something at 7 in the morning when I get up.
To me, that's adequate. Any of the other people on the call want to comment about that?
Yeah. Anyone else doing intermittent fasting on the call?
Sal, you got your hand up? Oh, John McPhee has his hand up for intermittent fasting. Sal, you got your hand up. Is that
Yes.
old?
Yes, it's maybe a little off topic, but I know I got treated at Sloan in the city, and I was told that they're doing testing now, trials, ivermectin and fenbendazole. Have you guys heard anything regarding that?
Without getting into a discussion, because we are so short of time, I would basically say no. I would disregard that.
Okay. Because they are starting trials on that. So.
Yeah, I don't think they're doing any of that at Memorial Sloan Kettering, Sal, to be honest.
Okay.
There's a lot, there's been a lot of talk, but it just doesn't have the value. John McPhee, do you want to talk about intermittent fasting?
Sure. It's how I control my weight gain is I skip breakfast basically, and lunch is protein and an apple, egg and an apple, maybe some yogurt. Not a big deal.
All right, thank you. Well, you guys that are new to hormone therapy, you're in for quite a number of changes over the next few months. Stick with us and we'll talk you through every step of the way. We've all been through it practically.
Yeah.
And welcome to group, new guys.
Yeah, I want to take something up with Nick. And by the way, Ann Kelso, I now finally got to putting both those links in the chat window for you.
Yes, I see them. Thank you.
Sal mentioned to me that your doctors told you that you shouldn't touch the drugs and you should stay away from your wife for 2 days. And
not stay away from her, but not but she's the doctor says don't touch the drug, put it in the cap and throw it in your mouth.
Okay. So I will tell you that I've been around this game for a long time, even before these drugs were approved. The first one to be approved was abiraterone. You're not on that. We've never heard this. But when Sal told me, I Googled it, and sure enough, it says, if you're on any of these ARSI drugs, you shouldn't touch them. Now, I would first like to know, this is real interesting for us. So some people are going to have to put their screens on, or you don't have to. I'd like to know, has anybody else been told that you should not touch enzalutamide, apalutamide, darolutamide, or abiraterone?
Nope.
So we've never, ever seen this before. Now, John, I spoke to John briefly because I was so astonished. I actually called John up. Bob Schwartz, will come to you in a sec. I called John up. I said, John, you ever seen this before? Because I was like, hello, what the heck is this? So much so that I think we'll write this up into our reminder. And haven't heard of it. Bob Schwartz, have you heard of it?
Yes, unfortunately, with the darolutamide, the Nubeca I take, they said, don't touch it with your hands.
Oh.
Okay,
Who
so
told you
one
that?
person. One
It's from
person.
RX to go. RX go.
One person. So I wouldn't be too concerned whether you touch it with your hands or you're not. Okay. You know, we're not giving you medical advice, but we've never, ever, ever heard of it. And in fact, with Bob here, it came from RX to go. It didn't come from his doc. So, you know, these drugs, as far as we know, are not dangerous in any way, shape or form if you touch them. Last question. Do we have your email address?
I don't think so.
Okay, no. We will definitely need that. We won't bug you, but you'll get a reminder every week with some great information in it. So you can put it in the chat window just to me or to everybody if you want to hear from any of the other guys. And I will need it because I want to communicate with you around about Duke.
Okay. Do you know if any of the doctors at Duke are associated with the 9/11 survivors?
No, but I can check with Dr. Dan and see. There may well be, but I don't know. But I will definitely when I write to Dan, I'll definitely ask him. He's usually real good about getting back to us, like within 24 hours or less. He really likes our guys. Len, you have something.
Yeah, regarding touching darolutamide or enzalutamide, it is in the package insert for darolutamide that a woman, particularly if she's pregnant or breastfeeding, should not touch those drugs.
Right.
It's okay for men to touch it.
Right.
But yeah, that's in the package insert.
Yeah. Bob McHugh, what do you know about touching the drugs? Or are you
Well,
pregnant?
first of all, I have sort of an esoteric question. How the hell are you supposed to take it if you can't touch it?
You have to put on rubber gloves.
Okay. Well,
I just drop it on the cap and pop it in my mouth.
Directly from the in-house pharmacy at Fox Chase, and I've never heard anything like this.
We will research this in detail and report to everybody. But I think it's going to come down to basically what Len said, because after all, if we absorb it, fine. Okay, we have gotten through the new guys. I have 7 regulars, so please time yourself accordingly. Damon is first. We met him a few weeks ago. We had a lot of open questions about his team, his medications, his metastasis therapy, his a number of things. So, Damon, please take the floor.
So with your urging, I did have an appointment. I had a 2-hour discussion with UCSF today. Really, wonderful.
Yeah.
And so I decided my care is being moved there. So that's happening because I haven't started any medication. The Sutter guys wanted to start me on the standard, the standard Luprin, Abby, and the prednisone, and just
Yep.
that. And I want to know what else is out there. And they said something a little bit different. The other guys were not recommending any radiation, but the USSF guys are going to take another thorough look at all my scans, my PET, my that kind of, even my biopsy from last year or a year and a half ago, and review all that. So that's the path I'm on now. He's going to order up the Orgovyx and the abiraterone, if I'm saying that right. That's the path. But then there might be some follow-up radiation. But I haven't actually started anything. The only decision was to move my care up there. I've also, sorry.
Who are you seeing? Who did you talk to?
So Rick, I talked to your not favorite guy, Eric Small.
Okay. That's fine. Don't say we didn't warn you, though. Okay.
No, well, the first impression. So I spent like 45 minutes, an hour with this fellow.
No, he knows a lot, doesn't he?
He does. Yeah.
Yeah, and the first hour was with this fellow Dr. Rao, his fellow he works with, and then the last hour was with him. After we hung up, my wife just kind of went, "Wow!" It's like it felt good. We felt like we were in the right place, right? So, and with your urging, my brother's urging, that's where we are. And
I mean that's great. I mean, you should know that he is the president of ASCO this year.
Yeah,
which is the American Society of Clinical Oncologists. It doesn't get. Now, we do have the former president of the American Urological Association with us today, which we are honored to have in Dr. Paul Schellhammer. But being a president of a major organization like that, whether they're urologists or oncologists, is a very, very prestigious position.
So that's my update. Things are in motion. I did do the Invitae test. I don't have any results yet. And I had just a bone scan to get a baseline, and that's what's happened in the last 2 weeks.
Was your bone scan negative?
No, I've got some midline. It was like minus 1.3, which is
a DEXA scan. Okay.
Yeah, sorry. Yeah, the bone density. Yeah.
So your DEXA scan was minus 1.3?
I think that's the number. I don't have it printed out here, but it was in that sort of mid-range, not great, not below the 2.9.
Right.
It's so good that we're urging people to get these scans at baseline.
Yeah.
Because ordinarily you just assume a guy is going to be perfectly normal, and you get the first scan years into the future.
Mm-hmm.
Now I'm really glad that you have a baseline that we know. It's minus 1.3 is not really normal. So
no, it's a little below normal. It's not great. I've been taking calcium and vitamin D for the past year. So
Damon, let me say it's a lot better than minus 2.4, which is what I found at age 56. And that was a hell of a shock to me. But
that's
minus
amazing.
1.3, it's just something to keep an eye on, especially when they put you on. And Small is concocting the best combination of hormone therapy drugs for you.
Yeah, so we're looking at all the options, but like I said, he's looking at the Orgovyx and the abiraterone with the prednisone.
Yeah,
that's what he wants.
That would be good to start off with.
Yeah, so and again, they're reviewing everything, and he mentioned some, maybe also some radiation, maybe even SBRT to look at some of the lymph nodes. The other guys were not recommending that. He's looking at that, so we might blast a couple of those. And then
Yeah. I mean, I think we mentioned to you that maybe some MDT might be in order, some metastasis-directed therapy.
Yeah, so that's being looked at too.
All right, good progress. Thank you.
Yeah, really good couple of weeks.
Tony G, you're next.
Okay, a few things to report. First of all, based on suggestion from this group, I have set up an appointment with Dr. Guercio at Wilmot Cancer Institute in Rochester, New York. Unfortunately, it's not the earliest he could get me is April 20th, but that is set up. In the meantime, I am still seeing my local oncologist, Dr. Duffy, Had an appointment with him last Monday, March 16th, and did a new round of blood work. So as of March 16th, after being on Orgovix for 19 days, my PSA is down to 0.081 from it was 1.36 on 2/9. Now that that blood work also found everything in normal range except for the BUN. The BUN spiked from 19 to 31. So the only advice they've had for me so far is make sure you stay hydrated, drink more water.
Okay. Was there a creatinine test on there?
Yes, that was normal. I think it went from 1, or it went from 0.9 to 1, or 1 to 0.9.
And was there a creatinine clearance calculated?
I don't, not something that I remember seeing.
Okay, this doesn't all sound too scary.
Yeah, the 316 creatine was 1.0. It was 0.9 on 2/9. So 1.0 is they're both in the normal range.
Okay.
Yeah.
And we wanted you to get a DEXA scan also.
Yes, I have that scheduled for this week, this Thursday. Yeah.
Good.
And so, okay, so within the same group, I met for the first time with their radiation oncologist, Dr. Chen. His first name is Shing, S-H-I-N-G. And the result of that visit was that he is suggesting to do 30 or 40 radiation treatments using IMRT and VMAT radiation.
Okay.
Okay, and he wasn't sure. He's saying 30 or 40 because he wasn't sure if we would do lymph nodes, because we don't have lymph node. There was no lymph nodes removed during my surgery, and so there's no N rating there.
And none showed up on your PSMA test either.
Right, two PSMAs actually, and none showed up. Right. Yeah. So, okay, and I also got the results back from BRCA screening. I'm negative. Yeah. And so discussion with both of those doctors about abiraterone. They're not quick to jump on that. My oncologist, Dr. Duffy, said that that's not definitely indicated because I do not have an N rating. Again, we don't have the definitive condition of lymph nodes. So,
Right.
yeah. So that was there. And also the discussion of the Acumen scan. Nobody's ready to jump on that because I've asked a couple of times, and even though the scan is available here in Syracuse at 2 different places, I think in order to get that, I'm going to have to push more if I absolutely want that.
Why are they negative? I mean, you don't have a result on your PSMA scan.
Right. My impression is that they just they don't use it. It's not something that they I don't know if they're not familiar with it or it's just, you know, right now I'm getting, you know, essentially getting their shoulders.
So here's what I would say, Tony. I would push for it sooner rather than later, because with your PSA dropping from 1.36 to 0.081, correct? I got that right. Yes.
Yeah.
In such a short time, we want to make sure that we see whatever's there, because it's going to make a difference. And yes, the radiation oncologist says, well, we don't know what's there. Well, they don't know what's there because they haven't done an Axumin scan. If they want to know what's there, they need to do an Axumin scan.
Okay.
And then maybe they'll see something. So we need to get on the stick and you say, I really want this, doc, and put it in writing. Don't ask them verbally, but put it in writing.
Yes. Well, I've written twice in the patient portal.
Okay, great.
Yeah.
Great. Fine. Because it might just show something and you might be PSMA, you might not make PSMA, so we wouldn't know. The other thing I just wanted to say is you've spoken with Tony Fig, haven't you?
I have.
Yes, okay. Because if not, I wanted to make sure that he's giving you his input on Dr. Guercio, but because we like Dr. Guercio, and we like Dr. Guercio because Tony Fig likes Dr. Guercio. That's the reason.
Okay. Yeah, I could have actually. They were Wilmot. They were very quick to get back to me once they got my records. They could have got me in sooner. They wanted to give me an appointment with one of Dr. Guercio's colleagues, but it appears that he's the only one with the credentials over there.
Yeah. Well, I would stick with that. But
yeah.
But if I were you, I would be pushing for that Axumin scan sooner rather than later, because if we're going to do some radiation, and again, I would leave that to Guercio to make that decision rather than Duffy, then that might be a good guidance as to whether to do it or not. And if you wait another month and a half or a month, nothing may show up on the Axumin scan.
Okay.
And Dr. Paul, repeat that BUN in a few months or not even bother?
I think not. I think I just stick with the current program.
Good. Yep.
Yeah.
Anybody else?
Yeah.
For Tony? All right. Very good progress.
Thank you.
Oh, well, yeah, one thing. Tony, 30 to 40 treatments sounds an awful lot.
Yeah.
I've got to believe that there is a better radiation plan for you if and when you need radiation. And this 30 to 40 treatments sounds like they're just going to blanket everything with a little bit so they get everything because they don't know where to shoot. And we don't want to put you through that. And, you know, if we can get some sort of if we can identify something with an Axumin scan, we may be able to cut it down to half that amount.
Okay. All right. I will continue the conversation with that, the Axumin scan, and you know, just looking forward to talking with Dr. Guercio. The other thing that's in my mind is the logistics of the radiation treatments. If I don't know if it's possible to you know, have Dr. Guercio as you know, my main you know, oncologist. And I you know, I don't know if I'm going to have to go, you know, if I have to travel to Rochester for radiation treatments, that's an hour and a half, and going, you know, 35 times for.
And how far is it for you right now to where this Dr. Tin or Lin or whatever his name is?
Oh, it's 15-20 minutes.
Okay, so
yeah,
what I would be doing is talking to, when you see the radiation oncologists at Wilmot, asking them who they work with in your local area.
Okay.
Because the likelihood that the guys with Duffy are going to take the advice from Wilmot is not great if it's different.
Yeah.
You know, but the chances are that they will work with other radiation oncologists who will listen to what Wilmot has to say.
Yeah. Okay.
I think that's quite possible.
Yeah. All right.
Happens all the time.
Yeah.
It's got to be convenient if you're going to have IMRT.
Right.
Okay, I've got Tom Matika next. And while Tom is talking, Rick, I want you to figure out how much we can go overtime because I got five more guys.
Yeah, we can go overtime. Nobody's using this room afterwards, and I'm happy to stay if Dr. John has to leave or Len has to leave.
Okay, Tom, we got probably some cardiology updates. Yeah.
Yeah, John, do you mean Thomas? Well, you asked for it, John.
What's your middle name? Look, he even wrote it in capital letters, so I would say Thomas.
Yes.
And I still didn't do it right. Yeah, go ahead, catch us up, Thomas.
Okay, I just have a short tip. You know, last week we talked about pharmaceutical intervention for nocturia, having to get up frequently at night and urinate.
Oh, yeah.
And you all gave me a bunch of those pharmaceuticals. That was great. I can research those. But a friend of mine said that he had luck, just with sleep issues with Tylenol PM, and generically that's acetaminophen and diphenhydramine, which is an antihistamine. And
the reason for that is because the diphenhydramine causes urinary retention, and it's probably keeping you from getting up and sedating you.
Yeah, and so I tried it. I couldn't believe it. I mean, I popped, a double dosage, and I didn't get out of bed for about 6 hours. It was great. I tried it again last night. It worked okay. So I'm just experimenting with that. Now, I would rather work with that for a while rather than go on a pharmaceutical. And maybe some of the men here have heard of doing that. And John, you understand it. So I just wanted to offer that.
And again, what is it that you're taking now that's helping you?
I'm taking individual tablets of acetaminophen, like Tylenol, and diphenhydramine hydrochloride, but you can combine them with Tylenol PM. That's what it is.
Okay.
Tylenol PM is a combination of those two.
Thomas, how old are you?
Me, 79.
Okay, they don't really recommend diphenhydramine for people your age. It's not good for your cognition. It's an anticholinergic, and you need choline is an important neurotransmitter in your brain.
Yeah.
So, I mean, talk to your doctor about it, but it's really not a good drug for seniors.
Okay. Yeah. Okay. Good. That's what I need. Thank you very much, Len.
Sure.
Let's call on Paul again for
the question I ask and to be wary of is you're not getting up as frequently, but how well are you emptying your bladder? And so something called a ultrasound of the bladder, just to be sure you're not developing gradual urinary retention, because that can sneak up on you. And you think you're doing just well, but it's what you're actually doing is storing more, voiding less, but storing more and not emptying completely. So just when you're in the urologist's office, might ask for that bladder ultrasound. Maybe you have one done. And
diphenhydramine can make that condition worse.
Chronically, yes.
Okay. Yeah, and I measure my urine at night, how much I urinate at night, and that's usually about maybe 1,500, 1,600 milliliters, quite a bit. And
that's good. That's good. And I
Good.
think that's, but how much you have residual in the bladder after
Yeah.
you urinate can sometimes, it's just a precaution, can sneak
Okay.
up, and it's a simple way of determining if you're emptying and not having any what we call urinary retention.
Okay. They can do a test for that?
Yes,
Very-
simple
it's
test
very
with an
easy.
ultrasound. It's
Oh, okay.
non-invasive.
Okay. Yeah. All right. Thank you.
Thank you, Thomas.
Yeah.
George, do you want to say anything before you
Ho-
leave?
Hold on, John, before we move on, please. I'd like to take this opportunity to just mention the new heart group that we're trying to establish. And we put it in the reminder. It's basically a group for anybody living with prostate cancer that also has cardiovascular related issues. So that would include AFib and anything like that. We got 6 or 7 people writing back to us. I think we have just under 10 people right now. I have to talk more with Dr. John about it, but we are just thinking of starting this with a male group, just like we do with our BRCA brothers with their inherited mutations. So if anybody would like to be part of that heart group, send me a message, and hopefully within the next 4 weeks you'll get an opening email, and then basically we'll just write to you whenever we've got anything of interest, or it'll also give you a number of people that you can reach out to if you've got cardiovascular related questions. But Thomas was one of the people that responded to me, so I just want to make sure that if there are others on the listening to the recording or others in this group, please be sure we'll run it for a while. John, you want to say anything about this prospective mailing list?
We're still investigating how much interest there is, but the heart is so important for everyone with prostate cancer that I hope we will generate some interest. George, I know you're on your way out the door, but do you want to catch us up a little bit? You haven't been here for quite a while, and briefly though, sorry.
No, I'm doing well. Yeah, I just want to wish everybody, good travels, and I know I haven't been here in a while, but it's still a great group. So I want to check in every once in a while and show my appreciation.
What's your latest PSA, George?
Oh, geez, it's below 2. If it goes above 2, I'll probably do a PSMA scan, which I've never had before. So, but it's been below 2 for years now. And I lost I got on those GLP-1 shots, and I took off 70 pounds already. And I got to tell you, I feel great. I mean, I was dealing with some weight issues, and obviously that can make the back a lot worse. And I'm trying to get my exercise in and do all those things. Diet, just the basics. Getting sleep. I got diagnosed with sleep apnea, so I'm working on that too. But it's once you got the cancer under control, it's all about just maintaining a healthy lifestyle. And
Sleep apnea is one of the many things that are being discovered to respond to GLP-1 treatments.
Yeah.
I'm so glad that's the reason you're looking skinny, because I noticed that right away, Dr. George. I noticed it right away. And
No,
I'm so
yeah, it
happy
wasn't.
that
It wasn't a bad thing. No, no. I know when I first got it, I lost quite a bit of weight, but you know, I had aggressive treatment, and it's nice hearing from the new guys. And I'm going to try to come a little more. You know, maybe I'll
That'd be
hit the
great.
under
That'd be
60
great.
weight too.
And I hope your pain is quite tolerable. I kind of favored the methadone plan, and I think it's working out.
Yeah. So thanks a lot, guys.
Bob McHugh. Oh,
Yeah, I just want to briefly sing the praises of darolutamide. I had a 3.5-year treatment holiday during which my PSA went up from 0.6 to 2.7. My GU med onc said it's time to do a scan. He found a half dozen lesions. He put me on darolutamide. I was on darolutamide for 5 weeks, and my PSA dropped from 2.7 to 0.04. So we're all very happy.
0.04. Okay.
is that
And
monotherapy?
Yes, sir.
Great. And that was from our buddy at Fox Chase.
Yeah, Dan Geinesman.
Geinesman, thank you. Yeah, great.
Yeah, I've been very, very happy with him, Rick. Very happy.
boy, that's pretty nice. And so, what do you think your testosterone level is like now?
It's around 400.
Okay. That means you've probably got some estradiol circulating as well. Well, this is something we would never have seen. We would never have seen this a few years ago. This is great.
It's a wonderful drug. I mean, so far so good. I will ask the group one question. I have had some tinnitus, ear ringing, and Geinesman said he never heard that before with daro. But if I wanted to stop for a week to see if it went away, he had no problem with that. So I don't know whether anybody in the group can add anything to that.
Can I call on Len for a comment on that?
Well, I'm not a good person to call on because I've had tinnitus for decades, long before I took darolutamide. So, but I've never heard of it. I never heard of it as a specific side effect of darolutamide.
Well, Len and I are having lunch tomorrow here in South Florida, and the good news is maybe the tinnitus will keep us from hearing each other.
Come on, really? Len has a restaurant to take you to.
Bob Schwartz will be joining us too.
Oh, great.
Excellent.
And Peter Monaco as well.
Oh, okay. The boys are all getting together.
Yes.
Make sure you send pictures so we can include them in the reminder. So I know a little bit about tinnitus, more now than I did a year or so ago. I've had tinnitus since I first recognized it in 1997, so I've had it a long time. I also wanted to tell you that I have another condition which I only recognized the name for last year. I didn't even think about it, which is highly related to tinnitus, which is a visual condition. So I wanted to ask you, do you have any visual issues, Bob?
No, Rick, because I'm diabetic, I get my annual diabetic eye exams, and I had one, I want to say in March or February recently, and everything was fine.
Okay, so but you don't have any interference in your vision, like that you might have gotten used to over the years, but like little dots or double vision or anything like that.
No, thankfully I don't.
Okay, then because mine is related to that. It's called visual snow syndrome, and we have a group for it. And that's how I figured out that I'd had it since a child. But I have not heard, I I've not heard about daro and tinnitus. Don't know anything about it.
Let us know though, Bob. I mean, I hate to have you be off darolutamide for very long, but let us know, because I'm kind of interested in this idea that the nerve that carries hearing to the brain is sensitive to certain drugs. And I'd love to learn more about it if you find out, if you do go off for a brief period of time, if it goes away, okay?
Yeah, as I said, I spoke with Geinesman, and I'm only going to take a 1 week break and see if that makes any difference. And he's fine with that.
Okay, yeah, that shouldn't. Okay, Jack.
Question, John?
Oh, wait a minute, I got a hand up. Yes, wait a second, Jack. Go ahead, Gary.
Bob, other than this possible short interruption, how long does he want you on it?
Gary, I don't know the answer to that. I don't know what the normal course of treatment is. This is the first for me. As I said, I was only on it for about 5 weeks and my PSA dropped significantly. So I don't know what the normal course is. Perhaps Len or Rick or somebody would know.
And you said it's monotherapy?
Yes, sir.
Okay, thank you.
I'd like to see an even lower PSA for many, many months first. I don't know what Dr. Geinesman will say. Thomas, you had your hand up and then took it down again. Did I miss you?
Am I still on here? Yeah. Well, no, I was just going to ask Rick if I'm not clear on what you're going to do with the with this gathering of people with heart issues. Are you going to just send out a reminder?
No, we're going to exchange information that might be helpful for people who have prostate cancer and heart. But that question is probably better directed at Dr. John.
And I don't really know the answer yet. We're still investigating.
Okay, thank you.
So write to us and we'll try to make some sense of everything and see what needs to be done.
I mean, it came out of a suggestion from a gent in one of the lower groups who just finds that he might have a heart issue. And he said, wouldn't it, and he's on the inherited mutation, the BRCA brothers group. And he said, wouldn't it be good if we could have a group of guys who are all facing heart issues? And so we can exchange interesting articles or tidbits that we find. And then as it turned out, we started a quarterly group in the inherited mutations. And if the group became big enough and there was interest, we would start a group from that just looks at prostate cancer and heart issues.
Okay, I'll bring up my issues in this this group then, if I have any.
Yes.
Okay, thank you. And hopefully,
thank you.
Is Steve Lodge on your list yet, Rick?
Yes, Steve Lodge is on my list. Yep.
Jack, please take the floor.
Yeah. All right. So I won't be too long. I just wanted to talk about insomnia. And you know, I was out at my backyard where I live talking to a buddy of some of you guys, Neil Fleshner. And he said, you know, you low testosterone guys, you know, you really have insomnia issues. He said, I think that's just a real tough thing to live with. And, you know, I've had low testosterone now for years since doublet therapy, past year on a holiday. And with this Clomid thing, it's worse than it's ever been. I'm off the Clomid now for, you know, a while, but I'm sleeping 3 hours a night. Benzos aren't touching me. I've never been like this in my life. I've got my daughter hunting out some THC up in New York for me to ship down to me because I need something because I'm going bonkers trying to get a good night's sleep. I've never been like this in my life, and I was wondering to what degree all of you have, you know, as a function of your low testosterone experienced chronic insomnia. And if so, how did you remediate it? How did you deal with it? I'm really at a loss. I've never had so much difficulty. When I was young, I could pop a diphenhydramine, you know, and I was out like a light. And I got up in the morning, you know, mild hangover, but it felt great to be so rested and other things. But now it's getting very hard. So whatever you can do to give me a few tips, I'd appreciate it.
Go ahead, Bob.
Yeah, my testosterone is normal, as I told you. I think it's about 400. About 2 years ago, a psychiatrist at Fox Chase put me on something called metrazapine. Remeron is the brand name.
Yeah, I
When it
take
comes to sleeping, for me, it's a wonder drug.
I know.
An absolute wonder drug. So
Doesn't touch
I
me.
just throw it
I-
out there as something to think about. It's an antidepressant.
Thank you, Bob. It doesn't touch me. I tried it.
Okay.
I'm a psychiatrist. I've tried them all.
Okay.
In my particular case, my testosterone levels are in the toilet, but my sleep is pretty, it's excessive actually, if anything. I get up to pee a couple times, but I can go back to sleep. So I'm lucky in that regard.
You are. That's nice.
Anybody else with hardly any testosterone struggling with this?
Gee, I'm amazed that Neil would say that today. He sort of generalized on it. And, you know, right away, he went right to that. He said, I have so many patients with low testosterone with insomnia. So nobody in this group has that?
Schwartz?
Jack, I have to tell you,
Did you
I
have-
did. Dr. John, my testosterone is like yours. It's in the toilet. But Jack, I got to tell you, it's been hard for me to go to sleep. What's made a difference to me is now I've just recently been put on the estradiol patch. It's helped a lot. It's not completely gone. The estradiol patch.
Oh, estradiol really makes a difference, huh?
Yeah, it's a low dose. It's 14 mcgs a day. It's a patch you put on. It stays on for 7 days at a time. Then you switch it. I found it to be helpful. It's not a cure-all, but it helps.
You find that to be true for you, Dr. Paul? The estradiol helps you sleep better?
Well, I mean, it helps with relieving a lot of the hot flash issues that cause sleep disturbances, but I'm not sure directly as a sleeping aid, if that's not an issue, how it might interact. But I hear what Bob Schwartz is saying and need to look into it further.
No doubt the hot flashes keep me up.
Jeff Wood?
Yeah, like I was saying, I was getting up, and I still get up a lot to go, to pee and all that, but I was having a harder time going back to sleep, with the hot flashes and all that. And this has now brought a more semblance of control to it, where I still have difficulty going to sleep, but now when I get up and go back to bed, it's easier. So it might work for you, it might not, but it's worth investigating.
Talking about the diphenhydramine, the Tylenol PM. Is that what you're talking about?
Are you talking about
estradiol patch?
Yeah. Oh, estradiol. Okay, Bob Schwartz, right. I thought it was the other guy.
Yeah. Yeah, it might work for you, it might not, but it's worth a try.
Yeah. Thank you.
Gary? Gary?
Thank you.
Got your hand up?
Yep. My testosterone is also very low. And I think it has affected my circadian rhythm, and I go to bed much later. But I don't have insomnia once I actually go to bed. But I think something has had me change my going to bed time.
I want to emphasize the importance of taking care of our circadian rhythms, not messing them up by irregular wake-up times, daytime naps, caffeine in the evening. Even if our circadian rhythms are damaged by our treatment, we want to make them as healthy as we possibly can because they do us a lot of good. Jeff?
I've been on ADT for 8 years. I've been undetectable for below 5, and I go to sleep about midnight, get up around 6:30, and last night 1:30 I got a hot flash and woke me up and But what I do is I set my wave device to night mode, and I don't wake up again. And I don't have to wake up to pee till the morning. It's just, I guess the Meyer-Betrick really works for me. But the wave device, if you have hot flashes, really makes a difference in the night. And it just stops those hot flashes at night completely, for me at least.
Thank you. Dan, quickly.
Yes. Just for my understanding, when you say your testosterone is in the toilet, that means it's very low?
Yes, I mean my
And,
testosterone level is about 20 in my case.
right, right. And so his question was, if you have low testosterone and you're having trouble sleeping, is that what the question was?
Yes, in Jack's case, he has low testosterone and he has trouble sleeping. The two are correlated in his case. We don't know what's causing what exactly, but that's what he's wondering exactly.
All right. Okay. And,
because we've seen low testosterone affect so many different systems in our bodies that we wouldn't think it would be affected, and yet they are.
Right, right. Yeah, because I've been having trouble sleeping. I'm getting to sleep. And of course, the hot flashes wake me up. I'm able to go right back to sleep. But getting to sleep initially, is causing me like problems. And my testosterone level was really low too. So yeah, so I'm having that problem too.
Yeah, I want to draw the distinction right now between those of you who are actually on a active hormone therapy treatment, like Dan, and those of you who are not on hormone therapy, you're on intermittent, so you're not taking a drug currently right now, like say Dr. Jack or Gary. Because I think there may be some sort of a difference. I mean, my hormone therapy completely screwed up my sleep habits, actually in a positive way. But having said that, I don't have anything to contribute to this conversation because I don't have low testosterone. But I mean, Dr. John is not on any hormone treatment, so he falls into that category too. But I think, don't you think, John, that we should be separating between people who are on hormone therapy with low testosterone and people whose testosterone has not returned?
Yes, it's a variable that we would like to know about so that we don't mistake a side effect of a drug for a side effect of having low testosterone. We're talking correlations here, but we really don't know what causes what.
John?
Yeah.
Just a quick insert, and what you said is absolutely what we think and is correct, that low testosterone is the culprit, but I have to just add the footnote that absent estrogen is also responsible. So the two go together. When you have low testosterone, you have low estrogen, so you are dual hormone deprived. Just I know it's getting to be an old sore, but got to throw it in.
Not at all. It's a great contribution, and it's even a more significant contribution when Bob Schwartz tells us that he's using that ES pack and it's helping him sleep. But I think, Bob Schwartz, you are on active hormone therapy right now, correct?
That's correct. Like I am on active hormone therapy.
Yeah. But it's still very relevant. What Dr. Paul says is very relevant.
I think
and,
so.
I'm not ready to carry the estradiol standard in front of all of you guys yet, Dr. Paul, but I'm getting to be a reliable trooper for you.
Well, without time to go into it now, there is a series of symptoms that we have formerly attributed to low testosterone that are in fact from low estradiol. And it's always good for us to figure out what is from what. So we can, because now we have a way of looking at them independently. But Jeff Wood, I'd like to get squeak you in here before we close and see what's on your mind.
Hold on, let's just let Dr. Jack finish up.
Let me just say, because Dr. Paul said something significant. My estradiol, for whatever reason, went up with the Clomid, and my medical oncologist said that's what happens with Clomid, and I didn't have the insomnia that I'm having right now since withdrawing from the Clomid. So I don't have the Clomid. My testosterone's gone down, and I think my estrogen has gone down with it, and I'm really feeling not only night sweats and sweating right now and hot flashes, but also this severe insomnia. And I don't know if that has to do with withdrawal from Clomid. Who's been on Clomid? Who knows about Clomid? But, you know, that has to have an impact on what's happening with me. Which is,
hey, you know, Dr. Jack, yeah. Dr. Jack, it seemed like a good idea at the time, right?
It did. It did. It really
and low dose of E2 is starting to seem like a possible good idea for Jack as well.
Well, and I also found out about oral testosterone that doesn't go through the liver, this thing called T-Lando. This is a new thing. Are you all familiar with that? I'm sure Dr. Paul knows about it. But that was suggested to me that you can consider starting on low dosage oral testosterone. And I know it's risky, but sometimes I wonder about the risk and the trade-off between.
I'd rather you start low dose estrogen.
Yes.
And you don't have any. Just put a patch on every week.
Yes.
0.1 milligram on every Monday.
You know, Dr. Paul was reading my mind as you're saying it. You know, we messed around with this bloody Clomid and it left you in a mess. Now you want to add some testosterone. No, I agree. Maybe you got to think about a low dose of estrogen, see if it helps you. See if it helps. If it doesn't help you, stop it. You know?
Right.
You know? Well, that's right. What do you got to lose? And if you're really worried, get a couple of shots of radiation to your chest before you start.
Okay.
All right, you guys. Let me get to Jeff. We're over time. Go ahead, Jeff. This is a great discussion.
First of all, I was going to encourage that somebody who lives next to Jack to roofie him with an estradiol patch.
That's right.
Quick update. Sadly, I've come to the end of a holiday and I'm back on the juice. I was off for about 1 year and 2 months after being on it for like 9 months for the second time. Unfortunately, I saw the long game right at the point that I was starting Orgovyx again. I guess I was, you know, as well as an update, was wondering if anybody has considered that. I did contact them just to see what they would have said to me.
Yes.
They would have advised. They said, yeah, we wouldn't have put you on anything. We would have waited. And I'm like, yeah. It's not fun to really analyze it.
So Jay Mills has been sitting around here very patiently, and we haven't even seen him. But eventually his cue comes and he can tell us. Jay, are you there? Yes.
Yes, I'm here. I'm driving down the highway.
Okay, this is your cue, man.
I spoke with Dr. Abel last week, and she went through everything, answered all my questions. It's very straightforward, and I need to have a bone scan and a PSMA within 6 months or something like that. The one I had that was within 6 months was not I can't remember the term they used, but it was not a full-strength CT scan. And they said they often don't do a full-strength CT scan. And it's a shame, because now I need to have another one. So we'll wait until June to do one, so I won't have to have one so soon. I just had one in December. And so those two things, and they needed a testosterone score. They needed to have my recent PSAs. And I'll be in the study.
So Jay is one person, Jeff. I have another, my close buddy, Dave Fisher, who's been on and off this a few times. He's leaving to go see his new grandson in Australia, who he hasn't seen yet tonight, so he didn't make the group today. He had a long conversation for an hour with Dr. Abel yesterday, and he's actually tossing up between the long game trial or this Andromeda trial that I think I put in the chat window earlier on. If I didn't, I meant to. Let me see if it's up there. No, I
know that my doubling time is like 3 months. Although again, they would probably argue that I'm not over 1 yet, so you really can't nail that doubling
right,
time.
that they would.
Yeah.
I'd love for you. I'm going to put the Andromeda trial in. I thought I put it in, but maybe that was last night. I'm going to put the Andromeda trial in. The problem with the Andromeda trial is you really should not have started, but you haven't started too long, so there may be a workaround. But the Andromeda trial is what I talked about a little earlier with Nick, where they're giving you, they're shooting the whatever lesion they see on your PSMA. And did you say you have had a PSMA or not?
Had one, nothing.
And they didn't see anything.
No.
So it probably wouldn't work for you. And they're also giving you either Pluvicto or actinium, 2 shots of Pluvicto or 1 shot of actinium, and seeing if that can hold off anything coming back, so you don't have to go on hormone therapy like you've gone back on hormone therapy.
Yeah, I was going to give Dr. Rakoff that, their kind of their information and let her kind of analyze as well and tell me what she is.
Yeah, I mean that's also that's definitely, Dr. Rathkov knows them well. I think she knows Dr. Ravi real well and has worked with him. But that's an alternative, and the Andromeda trial, of course, is in California, but it's a good damn trial. So I'm putting it in the chat window right now. There you go. It's there again. So that's, and now, do we have anybody else? I think we've had a couple of other people. Yes. The Baldridges have talked to NCI, and I think somebody else. And we've had and Robert. Robert was here before. Are you still with us, Robert? Robert signed up.
Looks like he's gone.
He's gone. But if you want to talk to Robert, let me know and I'll connect you. But Robert has already signed up. We've had quite a few people.
Well, it's certainly intriguing and scary.
Now, here's something that you guys don't really know about this trial, but the long game is part of a much bigger concept that the NCI has. And the concept is, how do we give the least amount of treatment and get the biggest bang for our buck? And they have a series of trials. So what happens, for example, with the long game is that when your doubling time gets too low and they have to kick you out, they've got another trial that they put you on, which involves monotherapy and enzalutamide. And so they try you on that. And then Dave told me yesterday that Dr. Abel said they've got a trial starting up in June or July where they're going to try using a couple of doses of Pluvicto to see if that'll hold you to save you going back onto Orgovyx like you've done. So it's part of a bigger plan that the NCI is doing to try and minimize treatment when the disease recurs. And I will say, and everybody says the same thing, that Melissa Abel is just lovely. She takes a lot of time. She's really concerned. She even called Dave back because she needed this technetium-99 scan and she didn't have it. Now, a lot of all of these trials have the same in common, that you can't have a lesion that is identifiable from your technetium-99 scan, because by that time you're too late and you've moved on. But as we well know, you can have recurrence, but it doesn't show up on your technetium scan. This is the old darolutamide issue that we worked with for years and years, where guys wanted darolutamide and they had recurrence. And we said, well, if you can show that you don't have any metastasis on your technetium-99, we can get you darolutamide. And that was the workaround. So that's what I got to tell you, Mr. Wood, and let me know if you want to be connected to anybody and you don't have their information. Steve Logan. You're muted.
Are you saying that you should not take darolutamide if you have metastasis?
No. I'm saying that when darolutamide was first approved, it was only approved for men who were non-metastatic castrate resistant. But non-metastatic castrate resistant is a tautology. How can you be castrate resistant if you don't have metastasis, right? Doesn't make sense. But what happened was that when they did that trial at the FDA, they qualified people to take the darolutamide who went in for a bone scan with the technetium technology and nothing showed. Didn't mean they didn't have metastasis. They didn't test them with PSMA because PSMA wasn't that widespread. So men who had metastasis that didn't show up on technetium could get darolutamide. So we'd send our guys back and say, because they'd say, oh, well, I'm metastatic. It shows up on the PSMA scan. We say, go get a technetium scan. If it doesn't show up, we can probably get you darolutamide. Is that making sense? No.
Is that still the case?
Well, the approvals for darolutamide have now changed. So now you can get darolutamide. The first place they changed was that you could get darolutamide if you were hormone sensitive and you did chemotherapy. And now what's happened, I think, is you can get darolutamide even if you haven't done chemo and you're hormone sensitive. Am I right, John?
We need Len now. I think so.
I think that's where it stands right now. So now, hormone sensitive, castrate sensitive, you can now get darolutamide since about the middle of this year, if I'm not mistaken. But I could be mistaken.
I believe you're correct, Rick.
Yeah. Yeah. So they've changed it around. But this business with the technetium scan was just a dodge so that Bayer could get an approval for the darolutamide. And, you know, now they're sort of using that at the NCI and saying, well, if we can see something on the technetium scan, you're not eligible for this series of trials that we're building, because by that time you're definitely recurrent enough that you're going to have to go into fuller treatment. But then there's a question of interpreting that technetium scan. Like in Dave's case, it showed up definitely on the PSMA, it lit up well. On the technetium, it kind of showed up, not 100% sure, but not 100% unsure. So NCI says, well, let us take a look at it and see whether we think you're eligible or not. If it were me, I'd do the Andromeda trial if I was eligible, because I get the feeling that if you're going to deal with a systemic treatment, right now in prostate cancer, you have three choices. You've got hormone therapy, either singlet or doublet, that none of us like because it sucks whatever you take. And as a subset, you've got monotherapy, ARPI, which could be a lot better, and it's worked well. It worked well for Bob McHugh. It's worked well for David Muslin, and so we often push that monotherapy, which is just the abiraterone or the darolutamide, apalutamide, or enzalutamide. So you've got that. The second systemic that you've got is chemo. Nobody wants to do chemo. You know, the bottom line, ABC, you're anything but chemo. No one wants to do chemo. The third thing that you've got now that's a systemic treatment, where we have the prince of radionuclide with us tonight, Mr. Chambra, who's done 10 treatments, is maybe we give what we gave Frank Chambra, but we give it to you much, much, much earlier in the disease process. And that radionuclide therapy nails all those little buggers that are swimming around. And this is what the Andromeda trial is testing. This is what NCI, Dr. Abel is hoping to test come June. And this is where hopefully we'll go to, because it has the least side effect. Yeah, there are side effects. You know, you're going to go through two Pluvictos or one actinium, and you're going to get dry mouth, but it's going to be done and dusted relatively quickly. Much better than hormone therapy, and certainly much better than chemo. Right, Mr. Chambra? Just give me a thumbs up. That's all. Just give me a thumbs up.
Yeah, so the Pluvicto really worked for me. And real quick, I know I came late because I had to pick up my grandchildren. So I was using THC the whole time I was on Pluvicto. And now that I'm off Pluvicto and I'm headed towards a clinical trial, my wife said that I needed to stop the THC, which I did, because she thinks that I'm going to be disqualified from a clinical trial because of the THC. But now, since I stopped, the Pluvicto seems to be wearing off and the THC is wearing off, and now more pain is showing up, and the sleep and that. Does anybody know about, if you can get a clinical trial? I mean, I'm probably going to test positive for the THC because I just stopped.
Oh my gosh.
Last weekend. Do you know anything about that?
It's such a great question, Frank. I don't think we've ever been asked that question. I mean, you never see THC as an exclusion criteria. Dr. Paul, I mean, we must have discussed this many, many years ago. I mean, what's the scoop with when they're doing trials? Do they test you for THC? Do you know?
Never did while I was working, and I've never heard it being done. No, I haven't.
So I have to see my GU tomorrow, and I made all my other doctors aware that I was using THC, but I never made Dr. Yang aware, and I'm wondering if I should make him. I think I should make him aware.
I think
tomorrow.
I think you should definitely.
Yeah,
definitely.
But I mean,
I also think, and by the way, Frank, there are a couple of amazing bloody trials at GU ASCO for people in your situation. Unfortunately, the one that's sticking in my mind, the VIR 5500, you might want to ask Dr. Yang about VIR 5500, which is the one that Johan de Bono is doing in England. But I think he's only doing it in England right now, but it's really for people just like you that have gone beyond the Pluvicto on what to do next. And it's a T cell, it's a T cell recruiter. It pulls the T cells right into the middle of the tumor, from what I understand.
Can you repeat the name of that again, so please?
VIR 5500. I've got it bookmarked. So let me put it, but like I say, I think it's only available at the Royal Marsden in England. Now,
yeah,
I was going to say the wife wouldn't mind a trip to London, would she?
No, I don't know if I can go out of the country. I don't have a passport. But my wife was talking about maybe the actinium. I don't think that's what
Well,
she was saying.
so again, that's a real interesting discussion. So this is a little article in Science Alert, and I also have the abstract, which I can send you if you want it. But this is a good starting point for VIR 5500. So we've had people that have tried actinium after Pluvicto, after the lutetium. I wouldn't say we've had outstanding results. We haven't had necessarily bad results. One of the problems is that it's been too late to think about it. But there are actinium trials in this country right now that for people like you, definitely. I would tend to think about more, and this is to talk with your GU Med Onc about some of these T-cell engager trials. AMG 50, somebody help me, 506, what's that one?
Yeah, we're talking to him about that one tomorrow.
Okay. I mean, those trials, to me, we're using a completely different AMG 509, xaluritamig. So, that's for you, I'd sort of be more interested in that. Only because it's a completely different, and you've gone through so much of the radionuclide, and the actinium is going to be a bit similar, very similar to that. So if it were me, that's what I would be looking at. Anybody else have any suggestions for Frank? Frank, why don't you ask for time in the meetings?
I came late because
when everybody's here.
I had to pick up my grandchildren today from school. So either I'll get the trial or I'll get the cabitaxel. That's what I think is going to happen now. But we're just trying to explore our options.
Yeah.
Because of the THC thing.
Yeah, I'm going to put an article that I've got, but you might have seen it already, certainly for your wife to read, on this 509. I'm putting it in. I'm putting 2 links in right now, and they're both for this AMG 509. And I haven't looked at them first, but I think they're both going to be useful to you. Okay, those 2 bottom links, just click on them, and then you can download them later. Those are both AMG 509. All right, we're 37 minutes over, but I will say that the time we've spent since the top of the hour has been really good. It was excellent for Jeff Markey. He's fallen right asleep. Look at that. Oh, no, he hasn't. All right, guys.
Nice job, Rick. Nice job.
Anything else from any of you chaps? Okay.
Take care.
Yes, tomorrow night. I forgot to tell everybody. Greg Burns, especially if you're on the West Coast, come on, and Steve Lodge, come and listen to Greg Burns. It'll be the link is in the reminder. If you have the reminder, so I don't have to put it down. I'm going to be talking to Greg about his life and times. He's just gone through his prostate cancer treatment. He's a Paralympian swimmer, crippled with polio as a child. He's a collectible artist with studios around the world. And he's going to be talking to little old me tomorrow for an hour, starting at 7:30 Pacific. So we'd love to see you there, if live, and to ask him the questions that I don't ask him. Good night, everyone.
Good night, Rick.
Good night. Good night. I want to put in.
Hey, Rick, this is Mike Cunningham.
Yes, Mike Cunningham.
Yeah, I've obviously got the schedule hosed up here. I thought this started at 5 to 7. Obviously, I'm wrong. Is it every other, the first and third Tuesday from 3 to 5 California time?
The first and third Tuesday from 3 to 5 California is correct. Yes.
Okay.
Okay.
Somehow I had it as 5 to 7. I don't know how that happened.
Sorry, let me just go there again. So I'm just writing something into the chat before I close the meeting. I don't know if I said it right. First and third Mondays is 6 to 8, is 5 to 7 California. First and third Mondays, second and fourth Tuesdays is 3 to 5 California.
Okay. I'll get that straight. I apologize for showing up late and for.
No, it's okay. You don't have to apologize. You come in, you go out. Let me